For the next minute, I want you to pretend you're a doctor, and a patient enters your office with an infectious disease. You know of a new drug that was just approved that has a great chance of curing him, with little side effects and in a fraction of the time compared to previous generations of treatment. So what do? Take out your prescription pad, write a prescription, both you and your patient walk away happy, right? Now what if I told you the course of treatment cost $100,000? On one hand, depending on your patient's immunity, other illnesses he might have, and how advanced his infection is, the drug may not be as effective as indicated. Also, there's a chance he might get reinfected because of risky lifestyle behaviors. On the other hand, if you don't treat your patient, his disease will progress, eventually making him very sick, leading to a drain on the healthcare system. And let's not forget your patient is still infectious, so there's a chance of his infection spreading to others. Now you're weighing the cost to the benefits while taking into account factors that could affect both. This example is the exact challenge healthcare providers are dealing with regarding the new hepatitis C treatments. Who should get treatment and who should pay for it? Decisions have been made using clinical trial data, however, this data does not reflect the real world. So wouldn't it be great to study the true effects of these drugs in a real-world setting? I hope so, because that's exactly what my thesis is about. 30% of people living with HIV are also co-infected with hepatitis C. This is a marginalized population with an overrepresentation of people who inject drugs, men who have sex with men, and aboriginals. And liver disease is now one of the leading causes of death amongst HIV-infected individuals, largely due to viral hepatitis. If co-infected people are not treated for their hepatitis C, over time their livers will get damaged, leading to end-stage liver disease, increasing their chances of dying considerably. Not since the introduction of highly active antiretroviral therapy in 1996 has there been a revolutionary therapy that could save so many lives. I will be evaluating the real health and economic impacts of treating HIV hepatitis C co-infected individuals with the new hepatitis C drugs. I'm using a large established cohort of co-infected people from across Canada that have been followed for the last 10 years. More than 30% of these people are eligible to receive treatment, making them an interesting population to observe who receives therapy and evaluating how well they do and the impact on the healthcare system. When using observational data opposed to clinical trial data, being able to identify the true effect on your outcome of interest versus meaningless associations requires a comprehensive understanding of epidemiology. That is why I'll be exploring the different quasi-experimental methods to evaluate the true effect of these new drugs. We are in the era of new challenges. Cures for hepatitis C are available, and due to financial constraints, important decisions will have to be made as to who receives therapy. I hope the results from this research provide insight into improving clinical care, not only in a cost-effective manner, but also to avoid health inequalities in this vulnerable population.